Welcome to the second webinar in the K2P COVID-19 Rapid Response Series. My name is Matilda Jabbour. I'm an evidence-based specialist with the K2P Center at the American University of Beirut, and I will be moderating the webinar today. As COVID-19 continues to spread around the world, digital health has emerged as a fundamental tool for governments, healthcare providers, and institutions to respond to the COVID-19 public health crisis. Today, we will start by looking at the different digital health applications utilized globally and in our region in the response to the COVID-19 pandemic. We will discuss lessons learned from their quick adoption and how the Eastern Mediterranean region can build on that momentum to further enhance their pandemic response capabilities in the immediate future and their healthcare systems more broadly in the medium to long term. We are joined today with three outstanding speakers: Dr. Kachnowski, Dr. Ahmed Mandil, and Dr. Marco Bardos. But before we kickstart our discussion, I will leave the floor to the K2P Center Director, Dr. Fadi Al-Jardali, to give a brief overview of the Center and our COVID-19 Rapid Response Initiative. Dr. Jardali, I will be passing the mic to you.
Thank you, Matilda. Thanks, everyone. Good morning, good afternoon. My name is Fadi Al-Jardali. I'm the director of the Knowledge to Policy Center, K2P Center, here at the Faculty of Health Sciences at the American University of Beirut. We are a center that work at the interface between evidence, science, policy, and politics. And we try to actually invest efforts in knowledge translation and trying to inform and shape policy decisions at different levels in Lebanon, the region, and globally. We are also honored to be the Bishop Oak Center for Evidence-Informed Policy and Practice, working with people like Dr. Ahmed and others in the World Health Organization. The one thing we want to mention about the K2P COVID series. So since the start of the pandemic, and since it has been really declared as a pandemic in March, we realized that in fact many governments have been really struggling with the type of response that they have to take to address the emergence and the transmission and how they deal with lockdown, relaxing measures, etc. So we've decided as K2P Center to have the K2P COVID-19 Rapid Response Series. So since then, we have produced several products, I think more than 15 or 16 products. We have a product that will be coming tomorrow and Monday related to school reopening. So we're trying as much as we can to be part of the discussion, but also trying to inform and engage with stakeholders, policymakers to inform and shape decisions moving forward. The one thing about the harnessing the power of technologies, and to be honest with you, we've seen that in fact there's a lot of governments that have invested heavily now in technology. And in order to address issues related to the pandemic and to the transmission of the virus. So, and we see that in fact with we have a new emergence of new technologies, big data, artificial intelligence to deal with this complex issues, particularly at the burden of disease, but also to address also the issues related to the pandemic. We see a big opportunity for strengthening a health system moving forward by harnessing the power of digital health in COVID to address COVID-19 challenges and beyond. And we're looking forward for this type of webinar. This is the second webinar we have as part of the COVID-19 series, and we're very much looking forward for that. Mind you, in May, we produced a document about the digital health in the context of COVID-19, and we are so pleased today and in fact honored to have distinguished members in this webinar to share their experience with us and to reflect and share insights related to the power of digital health in the COVID-19 era. Over.
Thank you, Dr. Jardali. Now my colleague will play a short video about our COVID-19 initiative. It's just 1 minute video.
Recognizing the need for trustworthy sources of evidence, K2P Center launched the COVID-19 Series initiative, the first of its kind in Lebanon and the region, to inform the pandemic response by harnessing the best available evidence and data and making it accessible to policymakers, stakeholders, and citizens in short periods of times, usually between 3 to 10 days. Through this initiative, K2P Center is responding to stakeholders' priorities and needs, as well as proactively shaping the policy agenda by bringing important and often overlooked issues to the attention of stakeholders. Given that no single entity can work alone to effectively control and mitigate the growing impact of the pandemic, the K2P Center initiative is catering to the needs of a range of stakeholders, from governments and policymakers to healthcare providers, municipalities, NGOs, and communities.
In a crisis of such growing scale and intensity like COVID-19, trusted sources of evidence are critical to address uncertainties and support policymakers in taking the right decisions. Organizations, initiatives, and networks supporting evidence-informed policymaking are an integral and indispensable component of strengthening public health systems and preparedness response. One of the best investments in the future is to invest in strengthening those entities and amplifying their role as the go-to hubs for trustworthy evidence that can inform policies and practice in a timely manner during public health crises.
Okay, so I will be starting with our first speaker, Professor Stan Kachnowski from Columbia University. Professor Stan Kachnowski is an Oxford-trained researcher. His teaching and research over the past 25 years includes educating graduate-level and executive students on 4 continents and conducting extensive studies on the efficacy and diffusion of digital health, including electronic data capture, EMRO, wearables, and predictive algorithms. Professor Kachnowski has authored over 200 peer-reviewed papers and presentations for national and international journals and societies in digital health development, management, and diffusion. Over the past 25 years, he has also served as interim CTO for life science organizations, including iTech and Oncology.com. He currently serves on the board of directors for Our Medicina, the Hudson Center for Health Equity, and Aptus Health. Professor Kachnowski holds bachelor's and master's degrees from the University of Vermont and a doctorate from the University of Oxford. Good morning, Professor Kachnowski. Thank you for joining us today from New York. We are thrilled to have you with us. Without further ado, I will move straight into my first question.
Wonderful. Thank you for having me. An honor to be here and joining your esteemed organization. And thank you for all the attendees who are also hopefully safe. And certainly my thoughts and regrets about the tremendous disaster that your city incurred, and hoping that you're all keeping safe with the pandemic as well.
Thank you. Thank you. We're trying to. So my first question, Dr. Stan, is COVID-19 has emphasized more than ever the role of digital health and innovation in expanding health system capacities and enabling governments to respond to public health emergencies. My question is, what are the different digital health tools used during the pandemic? How did digital health help in the emergency response? And what worked and what didn't work?
Yeah, these are really good questions, and this is something that even yesterday I was talking to a former student of mine, Marilise Gorgens from the World Bank, and we're trying to ascertain, which digital tools are working and which ones are really helping in 3 phases. Number 1, prevention and surveillance. Number 2, diagnostics, and number 3, treatment. And again, being in New York City at Columbia University, Columbia Business School, where the pandemic was absolutely the epicenter of what we were doing for a good chunk of March, all of April, and most of May. And now it certainly is a different situation. And you can see the data on websites like Infection 2020 and Johns Hopkins COVID-19 Resource Center. The data is there to show that through very rapid learning techniques, we were able to very quickly adjust our lifestyles and adjust activity through immediate shelter in place and quarantine and obviously the use of masks. I think it's important that we look at some other societies around the world and look at what they have done. And in talking to some of my colleagues at the Infectious Disease Center, it's actually OCRU, the Oxford Clinical Research Unit out of the Saigon Hospital in Vietnam, there were very little digital technologies utilized in Vietnam to manage the pandemic. And if you look at the Vietnamese case rate and the fatality rate, the mortality rate, it's stunningly low. And it's a 90 million person country with a massive land border with China, where the virus was first detected. So we have to understand that there's not always the need for digital. That many pandemics, not just in this era, going back with H1N1 and swine flu and bird flu, but also going back hundreds of years now, pandemics have been managed without any digital technology with extraordinary efficacy. That said, we have a much different society today. It's a globalized society. People are taking plane flights from New York to New Delhi for a few $100s, and you're seeing a new world of being able to rapidly travel. And in mega cities, again, like a New York or a New Delhi or Mumbai or Beijing, Shanghai, the amount of population living in close quarters, taking public transportation, living in massive apartment complexes and housing complexes, the need for the massive and the rapid surveillance and diagnosis, rapid testing, and the ability to treat patients who have signs, particularly of COVID-19, of even asymptomatically of the virus, is critical. And why is that? Because we know now COVID-19 is expressed through specific biomedical signals and has very different effects with different humans. So based upon the specific human immune system, and we're not quite sure exactly of the epidemiology of the disease, but there seems to be some sort of a genetic marker where some form of genetic makeup is more susceptible to the virus than others. And so the ability to, in real time, monitor what's happening within the human biology of the patient to see whether or not they're experiencing a rapid deterioration of symptomology, and being able to then immediately treat them with, again, we're seeing a variety of different, we don't know exactly what the best line of treatment is at this point, but we're seeing a variety of different treatments with extraordinary efficacy, even for folks, even for humans, even for people with more compromised immune systems and a more significant underlying healthcare condition. And so that's where we're seeing this need for digital to be able to, in real time, see the rapid deterioration of various biomedical signals, and these include remote pulse ox devices. So having a remote pulse ox sensor that the patient can bring home and wear and test, use on their fingers. One of the scientists I'm working with right now, she has developed a spit test on a piece of paper that can effectively give a rapid diagnostic to see if the body is beginning to move into a cytokine storm. So we're seeing a number of, and then that is, again, digitized and transmitted back to a hospital. So we're seeing a number of these digital technologies help in those ways. We're also seeing a number of surveillance tools, rapid data collection and generation and transmission to centralized databases. So having national electronic health record systems is making all the difference now when being able to understand which patient types are responding better to which interventions, either biologic or otherwise, what kind of drugs are working with specific DNA and specific patient types. So that digitization of the hospital electronic health record, et cetera, has provided new types of data and allowed scientists and physicians to work together to rapidly iterate new treatments in ways that we've never seen before. And then in clinical trials, it's extraordinary. So having an electronic data capture system and having a clinical trial database management system to rapidly assess in near real time how patients are responding to treatments, particularly in placebo-based double-blind trials, is an extraordinary component of the healthcare system that we didn't have even 10 years ago. roughly 20 years ago, about 2% of clinical trials were using electronic data capture. 10 years ago, that number had moved up to roughly 30%. Today, it's closer to 70%, and most trials, in fact, I think almost all trials today for COVID-19 studies are being done using electronic data capture tools, which is extraordinary. So companies like Metadata and other electronic data capture groups are providing tools for physicians and scientists, public health systems, to rapidly do clinical trials and understand the data within specific populations and be able to, because the data is coming in electronically, immediately do the biostatistical analysis that's needed to understand what's working and what's not working. So those are just some of the preventative, some of the diagnostic, some of the treatment digital technologies that we're seeing real efficacy in today's societies.
Okay, thank you for this comprehensive overview. Building on that, you have mentioned a list of tools utilized. Which of these tools are here to stay after the pandemic, and how will these tools change our healthcare systems in the future?
So that's a big debate, and everyone's having it these days, and we're trying to understand how much will governmental systems, national health systems, and again, in the U.S., our health system is predominantly, well, I wouldn't even say predominantly, our health system is about 50% private and about 50% public, plus or minus a few points here and there, and that's not including the people that are uninsured, which in the U.S. is a substantial population, and don't have health insurance. And so we have a significant debate occurring right now about how the government, and government is both federal and the state governments, will cover these sorts of technologies after the pandemic has passed. And so even right now, there's still significant debate about how much providers, how much physicians and hospitals are being paid. Because right now, the physician to utilize an electronic health record with a virtual healthcare visit requires a substantial amount of prep time for the physician, and then using the virtual healthcare tool requires some time, and then there requires some follow-up after the visit. And so when everything is put together, it's about 25 minutes per visit, and the reimbursement is not coming in to equate to what would normally be 25 minutes of a physician's time pre-pandemic. And so there's a debate about how much the virtual visits are currently being reimbursed and how much they should be reimbursed. And so now that we've seen some extraordinary growth, so Google has just invested into a massive telemedicine provider. We just had the sale of one telemedicine provider called Livongo to another one called Teladoc for $18 billion US. An extraordinary number, something that's unheard of in US history. We've never seen a transaction in digital health and biomedical informatics at this level before. So having an $18 billion transaction take place absolutely reverberated around the halls of the US healthcare system. And so now what does this mean? This means now that there will be lobbyists in Washington, D.C. that will be lobbying the federal lawmakers in the U.S. House of Representatives and the U.S. Senate and Health and Human Services Department and the Center for Medicare and Medicaid Services for greater reimbursement for the virtual visits. So our guess is that we will see much of this virtual healthcare system coming to a greater level of reimbursement, and we'll see more of this virtual healthcare system playing a part in the future of U.S. healthcare to come.
Okay, so is it only in the U.S. or worldwide do you believe it's going to have a greater role in virtual healthcare? From your experience, I know you work across continents and
Yeah, as a matter of fact, I would say that, most people are looking at this as a global experience. And the good news is the research I've done in India as a visiting professor at the Indian Institute of Technology in New Delhi is that certainly in most countries, medicine is not as regulated as it is in the United States and North America and in the European Union, et cetera. So there is a very good chance. If you look at the traditional model of medical technology diffusion, whether it's the smallpox vaccine or whether it's HIV medications, that the technology traditionally starts in the wealthier nations and rapidly diffuses through all nations. And so whether the technology is a vaccine like smallpox or a treatment like some of the HIV cocktails and AIDS cocktails that we've seen now provided at very low cost or free throughout much of Asia, Africa, Latin America, this digital technology is not different. And so we're probably going to see a rapid diffusion of very sophisticated virtual healthcare tools to countries all over the world, including the Middle East and Africa and Asia and Latin America. So I think that this is a technology that will become rapidly utilized. And frankly, a lot of brilliant computer scientists in the Middle East will be able to utilize some of the technologies that are made, and there'll be open source technology that will follow, very similar to what we've seen with electronic health record systems and clinical research systems like REDCap. So traditionally, the open source movement will come into the ecosystem and start something that will help the greater good, and not just the wealthiest 1 billion, but all 8 billion people on the planet.
That is great to hear. We've talked a little bit about the advantages. Now moving to the disadvantages and the challenges of digital health. While digital health has proven to be very useful, many ethical concerns were also raised regarding different digital health modalities. How do you see the effect of the rapid adoption of digital health tools on equity in regard to the digital divide? And what about patient privacy and cybersecurity? And what should countries do to address these concerns?
Again, I'll go back to my former student, Marylise Gogens from the World Bank, and she's taking this up in rigor because right now, in a lot of ways, digital technologies are reducing the digital divide. They're helping bring, in the supply chain, for example, they're bringing medicines to places in Africa and Asia and Latin America and Middle East that people would have never ever thought of before. And you're seeing companies like Facebook and Google developing drone technologies to deliver medicines to people that don't have homes by using GPS coordinates instead of addresses with postal address. And so there are new ways of using digital technologies to reduce a lot of these barriers. And again, a lot of those are through the supply chain and through other methods like that. But we're seeing, and Marylise will tell you this, then the World Bank is working on this and trying to help the world's poorest 100 countries find ways to utilize digital. And the Gates Foundation is working with this as well with MoTech, the mobile technology for clinical, or rather mobile technology for community health. And so the Gates Foundation, in combination with the Grameen Foundation, have put together, and I did a study on this in 2015 and 16 in Africa, a bundle of voice messaging tools for public health workers to utilize to deliver hundreds of messages to patients, particularly in this case, either expectant moms or new moms, about clean water techniques and breastfeeding techniques and different types of mosquito netting techniques and vaccination sources and supplies. So these sorts of digital technologies are out there and they're being produced to try to reduce the inequities in healthcare. Are we where we need to be? Not at all. There's a lot of work that needs to be done to reduce the healthcare divide, to reduce the healthcare inequities. And whether it's looking at the fact that a lot of algorithms that are being developed, machine learning that's being developed right now, they're being developed using populations in North America and the EU, and that's not the majority of the world population. The majority of the world population is sitting in Asia, Africa, Middle East, and Latin America. And so there's already a disconnect happening within the digital health community, and it's at least most of the community and the leadership of the community understands that there's a divide that's already developed and that we need to take immediate steps to reduce that divide and to come up with algorithms and machine learning that are actually developed and that are based upon populations in Africa, Asia, the Middle East, and Latin America. So there are a whole series of efforts being undertaken by groups like the Wellcome Trust, like the Gates Foundation, like the Dell Foundation, certainly the global funds, and absolutely folks that are sitting in the World Bank and the World Health Organization. So we're seeing a lot of these groups take this up, and there are really good cases where digital can help reduce health inequities, but there's still concerns, and there's still real concerns and real issues around how the digital divide is increasing as certain populations around the globe are getting better access and better outcomes based upon their not only access to drugs and services, but also information.
Mm-hmm.
There's a whole field of research I would really recommend everyone read up on around the asymmetry and asymmetrical information, so that someone in Beirut should understand the best practices for treating cancer, or treating diabetes, or treating heart disease, and that there shouldn't be this kind of information asymmetry between populations, even within Beirut, so that some people at the upper strata economically have better information and therefore can understand how to manage things differently and better than other people. And so the digital divide is algorithms, it's information, it's access to smart devices and apps through smartphones. So the digital divide is manifested in a number of different ways in the public healthcare system. And really what we need to do is take actions in whichever way we can to make a difference and reduce that asymmetry and reduce that inequity.
Thank you. Now that we have discussed the opportunities and challenges, if we are to apply this to our region, in your opinion, how can countries make the most of digital health and available resources in this field? What are some quick wins for emerging and wealthy markets like the Gulf, or for economically less stable countries like Lebanon and Jordan?
There's, and being a scientist, it's important that first and foremost, everyone is making decisions based upon evidence. There are too many technologies that are promising to deliver extraordinary results when many times digital technologies don't deliver the results that they're promising. So many organizations are out there testing these technologies, and many institutions, whether they're universities or think tanks or family foundations, are publishing copious amounts of data on what digital technologies are working and which ones are not working. And so in my research over the past 30 years, I've taught not only 5,000 students about various digital technologies, but I've also done over 650 peer-reviewed IRB-approved studies that really focus on proving and creating and developing evidence so that these technologies are proven before they're purchased. And that's important. So whether people are coming in from the Gulf and wealthier states, or whether they're coming in from countries that are not as wealthy, always look for that proof point. Look for the evidence that's been done by a third party, by an independent source. Again, universities are a rich source of this. Family foundations are doing a lot of this. Independent think tanks are as well. But look for that independent verification that the technology can deliver the results that it's promising. Now, a lot of times these are new technologies and they don't have that kind of evidence base. In that case, try to do a very small, quick study, 30 days. Don't try to put it into a patient population. Do the study with your own scientists or your own team and just see if the technology deploys as easily as it was promised, and see if the technology from an experiential standpoint has the same effect as the technology company has promised. And so the research model that I've developed over the last 30 years has 4 different pinpoints to focus on. Number 1 is technical. Are the technical attributes of the technology actually delivering what they promise? For instance, basic things like user acceptance testing, some basic qualitative research interviews with users using the technology for the first time. Second, economic. When the technology is being utilized, does it seem to either create new economic opportunities, or does it save money because it does something a little bit faster, better, cheaper? Third is experiential. Will the user have an experience that does not require a lot of friction? So the more the technology requires a Bluetooth connectivity point, or the more the technology requires some sort of training for the user to use because it's not intuitive, those friction points are dangerous not only for patients, but for nurses and physicians and public health workers, pharmacists, lab technicians, whatever player, whatever stakeholder in the system is trying to utilize it. That's a red flag if the experiential model is failing. And then lastly, clinical. And this is, in fact, the most important, but it's also the most expensive. To gather clinical evidence that a digital technology is, in fact, creating a clinical difference within a patient population takes time, it takes money. Most biomedical markers require at least 3 months to change, whether it's your A1C or whether it's cholesterol or whether it's BMI or something like that. So the clinical evidence takes much longer. It requires an IRB, an ethical review board, et cetera, in order to pass the test of ethics. So try to do those, but don't do those first because they take a lot of time. Work on the economic, the technical, and the experiential. You can do those studies in-house without using patient populations that need an ethical review board within 30 days. So this is a great time. Google Scholar, all of these other tools. You can go online and find these instruments for measurement. You can find these instruments for being able to develop your study very quickly and cheaply. And I would highly recommend that everyone pursue that sort of course before buying a new digital health technology.
Oh, thank you. So it's all about evidence, and it's music to my ear as a researcher, and I think to the K2P Center as well. So like the main point is evidence, evidence, evidence.
Absolutely.
Thank you, Dr. Stan. Please stay with us till the end of the discussion to answer our audience questions.
My pleasure.
We will now be moving the discussion to our regional expert, Dr. Ahmed Mandil from the World Health Organization Eastern Mediterranean Office. But before I introduce Dr. Mandil, I would like to remind our audience that they can share with us their questions through the WebEx chat box. Dr. Ahmed Mandil is Coordinator, Research and Innovation at WHO EMRO. He received his bachelor degree in medicine and surgery and master's degree in pediatrics from Alexandria University, Egypt. Subsequently, he received his doctorate in public health from the UCLA School of Public Health, USA. He was Dean, College of Health Sciences, University of Sharjah, UAE, and Secretary, International Epidemiological Association. He currently serves as board member, peer reviewer of scientific journals, including WHO Eastern Mediterranean Health Journal, Journal of Epidemiology and Global Health, Journal of Family and Community Medicine. Hello, Dr. Mandil. Thanks for joining us today from Egypt. We are looking forward to hearing your insights today.
Thank you very much. It's my pleasure and honor to be with you, and I thank the K2P Center for its invitation. We're really proud of the Knowledge to Policy and Practice Center at the AUB for being our WHO collaborating center on policy and evidence to policy and practice, being the only one in our part of the world. I would like to add that our hearts and minds are with Lebanon during these difficult times. Over.
Thank you, Dr. Ahmed. Dr. Ahmed, Dr. Stan discussed different applications of digital health. However, for the Eastern Mediterranean region to harness the power of digital health, it would need the proper infrastructure and the enabling regulations. How would you assess the region's readiness on these fronts?
Thanks very much for your question. And just to add to what Dr. Stan was just mentioning, our region happens to be a very good example of digital divide. The ICT infrastructure and regulations differ dramatically from high-income countries in the Gulf, Saudi Arabia, Kuwait, Bahrain, Qatar, Oman, and the UAE, to middle-income countries, to the least developed countries in the region like Yemen, Somalia, and Djibouti. It is estimated that almost half the people in the region remain unconnected to the internet in spite of having more than 100% mobile subscriptions and high levels of broadband coverage in some of them. According to the International Telecommunications Union, there is positive correlation between mobile internet penetration and various socioeconomic measures, potentially greater for developing countries and least developed ones. Such countries were on track to reach 90% mobile broadband coverage with relatively affordable internet by this year, but less than 1 out of 4 will be using internet, significantly lower than the global average of around 50%. It's also to be noted that large numbers of people unconnected to the internet, particularly in least developed nations, would have a significant impact on access to basic services, including educational services, health services, financial services, or even governmental services. So there is this big divide. You hear about e-government in Dubai, and you hear about very traditional services in other parts of the region. And this is even worse or more apparent in rural areas, in marginalized communities, in remote segments of societies, and also among the populations we have in this part of the world, what we call the migrant, refugee, and IDP populations. Unfortunately, this part of the world carries 1/3 of the migrant population worldwide. Over to you.
Thank you for your input on the region's readiness. From the consumer's perspective, how would you assess the population's readiness to adopt digital health? For instance, are people in the Middle East or Eastern Mediterranean ready to have virtual consultations or to chat with an AI-enabled chatbot?
This is a very good question, Matilda. Thank you for it. We always have to consider the intertwined relationship between factors as availability of technology, its affordability, accessibility, as well as the culture of citizens and residents in our communities to use them. So readiness to adopt digital health would largely differ from one country to another in the region, depending on level of income and status of digital transformation. While the COVID pandemic we have been widely observing that more countries are accelerating efforts to digitally transform and provide necessary tools for consumers to adopt different governmental services, including digital health. It also seems that consumers are quite eager to adopt digital technologies in general, judging from their keenness to purchase smartphones, learning new tools, probably for their connectivity, livelihood, eagerness by them to find better access to digital health services. And we have noticed this across generations, from the very young to middle age to even older people in our communities. A very interesting change, which we have witnessed over the past few months. We have seen some countries in the region using digital solutions for contact tracing, using mobile technology for health promotion and protection, so-called mHealth, domestic distribution of medicines for non-communicable diseases, using telehealth and telemedicine platforms more than ever, not only for teaching purposes, but also for providing medical consultations, diagnosing and managing patients. You are now hearing about applications as EMCH, ENCD, and so on and so forth. This is in addition to introducing EHRs, or electronic health records, more than ever, and eagerness to improve connectivity and health management systems at large. Nevertheless, it seems that what's lagging in our ecosystem is access to broadband in developing as well as least developed countries in the region. This is largely due to lack of proper infrastructure, enabling regulations, as well as increasing investments. Fortunately, all of these factors are accelerating due to COVID-19 pandemic. Over to you.
Thank you. This is very motivating to hear. After we have discussed the region's challenges and readiness, my next question would be, what are the WHO's priorities when it comes to supporting regional governments in developing their digital health capabilities?
Thank you very much. I will actually move very quickly from global to regional in order to address your question. So globally, WHO now has a science division for the first time ever since 1 year. And it also has a chief scientist also for the first time. And under the science division, we now have a department called Digital Health and Innovation, which hasn't happened for many, many years in our organization. We actually strongly support the intersectoral approach to digital health, involving different sectors: health, telecommunications, science and technology, whether from the public or private sectors, civil service organizations, NGOs, as well as UN and funding agencies. We strongly recommend that countries in the region identify their national priorities in health, as well as national public health priorities and conduct situation analysis concerning available digital infrastructure, comparing demands with supplies. We did conduct a regional survey in the region in the last couple of years. We also support analyzing main health problems in served communities, be it communicable, non-communicable, health systems, health emergency preparedness and response, reproductive health services, and then identify the digital health solutions for such prevailing problems, which are conducive to available technology, resources, and culture in served communities. We also support capacity building on developing national digital health strategies. And ITU, along with WHO, has a toolkit for developing national e-health strategies. We actually conducted 2 workshops for this regard recently, one in Cairo, end of 2017, and another in Beirut during November 2018. We also support conducting national dialogues of stakeholders to support development of such national strategies, involving healthcare delivery agencies, NGOs, telecom operators, and other sectors I referred to earlier. And we held one in Pakistan last year, which was very, very successful. After all of this, we actually encourage development of specific plans for developing developing of these strategies and the related activities, as well as supporting utilization of modern and mobile technologies for health promotion and protection. In fact, WHO has a special initiative called Be Healthy, Be Mobile, and this is implemented in 4 countries in the region, in Egypt, Tunisia, Sudan, and Libya. And this is helping the control of diseases as diabetes, tobacco, bronchial asthma, and some types of cancers through the utilization of SNSs, because now we know that almost everyone has a mobile phone, if not a smartphone. Sometimes they say that the census of mobile phones sometimes is more than the census of the population itself, because some people now have more than one mobile phone. So this could be really used for raising awareness of the populations and control of many diseases, including non-communicable diseases. Recently, WHO has been supported online course for the continuous for the CPD and CME, including a course which has just been launched, which is an online course for primary healthcare in the context of the COVID pandemic. We also have a regional professional diploma in family medicine, which was designed to be online 80% and 20% face-to-face. And when all what happened recently has happened, now we're moving into a predominantly online application for the delivery of this professional program. WHO has recently held an expert consultation in our region last February, and it came up with regional strategic priorities. These are summarized as follows: encouraging and assisting countries in adopting digital health policies and architecture aiming at nationwide digital health solutions, encouraging and advising, supporting and injecting funding for digital health adoption. We also support digital health governance in member states and strengthening partnerships with primary care as well as hospital management leaders. We support increasing and improving human capacity building in digital health, raising awareness among provider, consumer, and general public, promoting the use of common standards and interoperable solutions, ascertaining nationwide services by stressing the importance of connectivity, especially for the underserved and remote populations, promoting and supporting digital health research and innovation, which was referred to by Dr. Stan, and keeping engaging stakeholders during implementation of digital health strategies. In addition to all of the above, we also support nowadays having regional webinars like the one you are conducting. We had one a few months ago during which K2P has participated, and we were honored by its participation. Over to you.
Thank you. For the sake of time, I will be moving directly to Dr. Marco now. But before I introduce Dr. Marco, I would like to remind our audience once again that they can send us their questions through the WebEx chat box. Dr. Marco Bardos is an assistant professor at the Department of Health Promotion and Community Health, Faculty of Health Sciences, American University of Beirut. He holds a PhD in Communication Sciences with a focus on health communication from USI University of Lugano. His research is aimed at understanding how persuasive communications and social marketing strategic thinking can be applied in health promotion and behavioral interventions among various populations and settings. His research focuses on the use of digital technology for behavior change. In relation to the COVID-19 pandemic, he is a member of the expert committee on COVID-19 at AUB and is involved in risk communication and community engagement activities at the national level. Welcome, Dr. Marco. We are thrilled to have you join us today.
Thank you for having me. Thank you very much.
Dr. Marco, I will start with my questions. Dr. Mandil introduced a little bit how the Eastern Mediterranean region are leveraging digital health. From your perspective, what are the key digital health tools currently being used in the region?
Thank you for the question. I think the esteemed colleagues who preceded me have already anticipated some of the applications that have been used or they are still using in this area, in this region. I think I want to mention contact tracing applications. I want to stress on that aspect. First of all, because we, with other colleagues of the Humanitarian Engineering Initiative at AUB, we have analyzed 114 applications developed globally. We specifically looked at those applications that are publicly available and they, for which there's an information related to the permissions. So we analyzed what information they collect and their privacy policies. So we completed an overview of these apps. We downloaded some of them, we tested them. We identified 12 applications developed in the Arab world, including Algeria, Bahrain, Jordan, Kuwait, Lebanon, which was launched a few weeks ago, Oman, Qatar, Saudi Arabia, the UAE, Tunisia, and at the same time, there are different versions of applications in the UAE. Now, there are differences in the way these technologies operate, but I think we can talk about it later. I wanted to mention another thing, and this is something that we are familiar with being at AUB, the use of telemedicine for delivering online consultations, for example, or follow-up visits, of course. I mean, when you need a physical checkup, you cannot do it necessarily through a mobile phone. So these are another type of technologies that are using mobile phones in order to interact with people and physicians and the healthcare system. So the assumption is that people know how to use the mobile application. They need to have internet connectivity, a broadband possibly, and on the other side, we need to have a trained physician who knows how to use the technology to the best way possible. I want to mention another type of technology that has been increasingly used, but in countries that are somehow affluent with more resources, artificial intelligence to detect in COVID-19 context, to detect, to analyze imaging, for example, of specific, CT scans to identify the disease when this has been used, for clinical identifications in different settings. Okay. However, the issue here is not only what technologies can do, but how can they be used by the population. And I raise the point here that we need to make sure that these technologies, especially contact tracing applications, are socialized, are used among the population, the majority of the people. Otherwise, they have no use. Technologies such as these are just tools for me. This is my opinion, of course, are just tools that complement the analog activities that a ministry or a government is doing already. So they are not the silver bullet that will exacerbate, that will eliminate the disease. Over to you.
Okay, thank you. You mentioned contact tracing applications. Exploring more on that, what are the different types of contact tracing applications used and how do they work if you want to give our audience more information on these applications?
Okay, yes, with pleasure. So there are two basic types of contact tracing application. The ones that use a centralized approach and the one that use a decentralized approach. By centralized approach means that they utilize servers that are based in a specific area, like could be under the Ministry of Public Health or in an entity, certified entity, and they might use geolocation, so GPS-based data. The decentralized approach are tendentially use privacy-preserving frameworks, which are based, for example, on Bluetooth, low technology energy. Different protocols have been developed since April, or actually before that. There are several applications that developed different frameworks. One is the COVID Watch, developed in the United States and with the University of Waterloo in Canada. Then there's the Bluetooth Low Energy, as I mentioned before. Then there's a group of European universities spearheaded by the École Polytechnique Fédérale de Lausanne and the Fraunhofer and Heinrich Hertz Institute. They developed a pan-European privacy-preserving proximity tracing. It's a mouthful, I know. So it's PEPPPT. And then there are different protocols like the Blue Trace protocol used in Singapore. They use a slightly different technology. Then more recently, since April 2020, Google and Apple have joined, let's say, their forces to develop their own exposure notification APIs. And these, again, utilize Bluetooth technology. Now, how do these applications work? Those that are using Bluetooth technologies, basically they exchange numbers or codes between devices in an anonymous way. They don't collect personal information. They tend not to collect personal identifying information. In some cases, though, some of these applications might ask the user to activate the location, but this is an application this is a case only for Android devices. I'm not going to be too much technical here, but this is an element related to the development phase. I have some experience, I've been involved in the development of the mobile application for contact tracing in Lebanon. And there was a decision from the developer side to use this type of permission in order to be applicable for most mobile phones, most smartphones that have Android 5 or above. In other countries, like in the UAE, like in Saudi Arabia, they develop an application or applications that use a younger version of the software. So Android 9 or 6 or above, which means that only the most advanced smartphones can use the application. They work similarly, but they can make a difference in terms of perception. And people might say, why do I need to activate my location when I install an application? Yeah.
Exactly. You have just introduced my second question. So looking at these applications worldwide, a lot of privacy concerns were raised regarding the information they collect, since they collect private information about your location. Did we have a similar experience in the region? Did we have, from your experience, are people in the region also concerned about their privacy? And what are governments in the regions doing to safeguard the users' privacy in the Eastern Mediterranean region?
Well, I think, the variation across the country, we need to consider this as an important factor. From my experience here in Lebanon, the compromise has to be done between public health value and privacy. So of course we can say, data are preserved, are maintained. If you're using application like the one developed in Lebanon, there are no personal identifiers collected. There is no GPS location collected. The data is not collected. Now, because of what I mentioned before, the permissions in Android need to be fixed in a way so that the Bluetooth technology can work. So this is a fixing specific element here. The problem is that what do we do with this data? So what is the data that the applications collect and what do they do with it? Now, we have to bear in mind that these contact tracing applications are a supplement to the analog or the traditional contact tracing efforts that the ministry is doing. So without the application, the Ministry of Public Health will still call people that tested positive for COVID-19. This is the regular contact tracing, because whenever a person goes and does a PCR test, they will leave their mobile phone number. So the phone number is stored somewhere already. And plus, there's no privacy with that regard with mobile phone number, especially in Lebanon. We know that the phone numbers are, let's say, under the control of different organizations. So we cannot really be isolated in a sense. Our privacy can still be violated, but the privacy is not the issue. It's the confidentiality of the data we collect. Now, these contact tracing applications are really low in terms of information. They don't collect a lot of information, but there are cases in the world of the application we analyzed. We calculated a sort of a permission and level of danger score for these applications. And you cannot believe that some applications, even in Europe, are very intrusive. So it's not only about the GPS that we have to be worried about, it's about whether these applications can access the storing of the files in the phone, can access our camera or the microphone, or can turn on and off the phone itself. These are really somehow more dangerous permissions that we need to give the application in order to work. It's not only a matter of consuming more energy, but it's also a matter of being more intrusive. And so I think we need to talk about the user here, the user experience, and I think this was mentioned before. So the fact that are these applications easy to use? Definitely so. You just install it, you activate Bluetooth, and they are working. But then you have to ask yourselves, what are they really collecting? So, and this is where you need to pay attention, and you need to look at probably at the privacy policy. The privacy policy of this application should mention exactly what data is collected and where it's stored, for how long. So all these data are included in that. I think, I can conclude here.
Okay, thank you, Dr. Marco. I still have one last question that is a little bit broader. From your perspective, what are the immediate next steps Eastern Mediterranean countries need to take to build on this rapid advancement in digital health observed during this pandemic?
Well, I think major important aspect that they need to consider is probably a better integration between the public health system and so integrating workflows between the digital part and the traditional part in contact tracing, for example. So the test, trace, and treat strategy should be probably implemented better, along with campaigns that explain better how these technologies are used. Because we are living in a context where we have a low trust towards government, low trust for various reasons. I'm not going to the political aspect of it, but is a generalized lack of trust towards institutions, not only in Lebanon, but in many parts of the Eastern Mediterranean region. So whatever the government is doing, people will still be reluctant of following the instructions or following the strategy. So from a behavioral standpoint, how do we gain trust? Is by showing consistently that we deserve to be trusted. So we need to be transparent. We as institutions, we as public health professionals, we need to be transparent, explain how things should be done. And this brings me to the fact that in some cases, from a communication standpoint, this pandemic has not been very well managed. From a communication standpoint, there's still a lot of uncertainty, still a lot of misinformation out there. And the technology has also, some aspect of that, has exacerbated the misinformation that is out there, about, social media and, WhatsApp messages that circulate. So it is a problem, I think, of digital literacy. It's a problem of health literacy. It's a problem of, generally speaking, it's a social divide. It's not only about using or having a technology, it's how to use it. So if you assume the so-called usage and gratification framework, this is in communication scholarship, it's very famous for that. So every device, every technology has a specific use. So I'm using a mobile phone for a specific need that I have. So if I fulfill that need, I am satisfied and I'm going to use that technology again. So we as communication scholars, we as communication professionals, public health professionals, we need to explain better the use of this technology in order to be adopted. However, we need to also consider the compromise between privacy sometimes and the public health value. So if an application like a contact tracing application is completely anonymous, and I rely on the fact that users voluntarily share their information and the exposure, potential exposure of people that have been tested positive for COVID-19, this might not be the case. It might not appear. And then it's another option. I think here we need to probably have better investments in the strategies that Dr. Mandil was mentioning. So there are national strategies for e-health, but are they really enforced, or actually are they really implemented as intended? I think this is a key issue for the future. So there are plans, there are strategies. Now we need to implement them and evaluate them. And I close here. Thank you.
Thank you. Thank you, Dr. Marco, for your very insightful input. We will now start addressing the audience questions. I will start with a question to Dr. Marco because it's very relevant to what you were just talking about. One of our audiences want to know what is the if you have information on the acceptability rate for the COVID-19 tracing app, the Ma'an app, if people are accepting it, and if not, if they have identified reasons for not accepting this application.
Thank you for this question. It's very interesting, and indeed, it's a very important aspect to consider. I'm not aware of any efforts done so far because we launched it recently, and you have to be very clear and very transparent in the sense that it's been a team effort involving the different units of the Ministry of Public Health and some colleagues at the AUB, so for the humanitarian engineering and the faculties are involved here. So I am one of the members of this team. We are considering doing so, but this is sort of a research proposal to be built inside that. We were not successful in getting funding for this application. So everything that has been developed pro bono, including the time that we dedicated in development or in the development of the content of the application, the development of the communication strategy and the logo and everything else. Now, how do we consider testing the user acceptability? We can use different indicators. One of the indicators might be the ratings on Google Play or on the stores, the Apple Store. It's not enough. So I would say I would rather do a small study and testing whether and understanding why people are not using the application or why people are using application, understanding their beliefs and the barriers, the perception they have, before then we rule out this. However, we might not have the time to do so because we launched it nationally without the steps, but we planned it to do so, but we were not successful in getting the funding.
Okay, my next question is for Dr. Stan. Dr. Stan, one of our audiences has raised a very relevant question to the World Patient Safety Day, which happens to be today. Are there enough studies evidencing patient safety in virtual consultations? Are there specific specialties where virtual consultations were found to be safe and others where they were found to be unsafe?
Yeah, that's a great question, first of all. And yes, it is in fact Patient Safety Day, and wishing everyone a safe Patient Safety Day. Ultimately, the evidence right now around virtual care systems and telemedicine systems around safety and efficacy is still for debate. There's nothing in the published literature that's showing that there's significant risks around this. And in fact, when it's studied on a population health basis, and a lot of what we're seeing on a population health basis and risk basis, telemedicine and virtual care substantially improves the access to care, at least to some foundational information and some very basic information, such as, do I have an infection that needs to be immediately treated with antibiotics? So for someone who's living in a village that is a day's drive from the nearest drug supply source or hospital, that could be a life-changing decision if they know that through a phone call or a telemedicine visit with a physician, that what they think is maybe just something that can avoid going to treatment for antibiotics, if they see that in fact they have a dire infection that should be treated with antibiotics, it could save their life, because oftentimes people that live in remote parts of countries don't get to those sources of antibiotics until it's too late and their body is falling into sepsis. So there are many, many different ways that telemedicine is actually improving access. In India, where I've traveled to 42 times over the last 20 years now, in India, the ability to dial up physicians in a very free market kind of way has allowed patients from one part of India to dial up physicians in a completely different part of India and receive medical consultations around these sorts of conditions as well as many others. And in today's society, we're seeing an extraordinary amount of mental health conditions, anxiety and depression because of the pandemic, because of the economic stress and strain that's falling on everybody. And so we need more access to physicians and healthcare professionals than ever before. And I think that we're seeing the evidence move more toward a population, certainly a population health improvement with the increased access to virtual care and telemedicine.
Okay, thank you, Dr. Stan. I will be moving to the third question. It's about the region's readiness, so I will be addressing it to Dr. Mandil. Dr. Mandil, our audience want to know what are the main barriers to the adoption of digital health in the Eastern Mediterranean region, and why are many countries still lagging behind in digital health?
Thank you very much for, I think, a very difficult question to answer. But I think I alluded to it while handling your questions earlier. This region is very heterogeneous when it comes to readiness to adopt digital health. This has to do with the variability in the socioeconomic conditions in countries of the region, in the digital infrastructure, in the acceptability and culture of using new digital health solutions. And this is probably why it really varies from one country to another. And I think this will remain for some time. But what we can see now very evidently is the acceptability of the wide majority of people of mHealth solutions. So utilization of mobile technology for health protection and promotion, be it non-communicable or even communicable diseases like the pandemic, has been now quite successful. Over.
Thank you, Dr. Mandil. The third question is again about contact tracing apps, and in Lebanon, I will be addressing it to Dr. Marco. Dr. Marco, our audience want to know at what point after receiving treatment should the tracing of a COVID patient stop?
I'm not clear. I'm not understood it clearly. After the treatment, the person that is treated and he or she will recover from the virus possibly, and so there's no tracing happening anymore. So the contact tracing application helps when the person becomes, one person becomes positive, tested positive, and this will trigger the notification in the network. Now there is a risk management risk model behind the application. It will notify the people that have been in close contact with the positive case based on distance, time spent together, and so on. And therefore, these people will be alerted that they've been in touch with a positive case in the last 14 days. But after these 14 days, the application will erase the data. So whenever there's a new case tested positive, then this will trigger again the system, let's say. I don't know if that answered the question.
Yes, thank you for clarifying this for our audience. So the tracing is before once the patient is diagnosed, they will trace everyone who he have been in contact with, and after that, they will stop tracing him as he will be in treatment already.
Yes, correct.
As we have no more pending questions from our audience, we will conclude our webinar for today. We would like to thank our speakers for sharing their very insightful thoughts on the role of digital health in the COVID-19 response and the next steps countries in the region should take to harness the rapid adoption of these tools during the pandemic. We would like to thank our audience for tuning in to our webinar, as we hope this discussion was up to their expectations. Please keep an eye on our social media accounts to learn more on our future publications and webinars, and to check our blog, including key insights from this webinar. Thanks again for joining us. The webinar will be concluded now.